Yeah, I'll start.
Yeah, madam, you can start.
Yeah, we have around 100 people with us now. So good morning, everyone. I wish everyone a happy Navratri and a happy Dasra. So on this auspicious day in the morning, we are having this masterclass on empty follicle syndrome, or how to evaluate or understand the empty follicles. So without wasting much time, I will hand it over to Dr. Jay to take it forward. Yeah. Yes, sir.
Thank you, ma'am. I will just start the screen sharing immediately. And what is important for us to understand, see, empty follicles is something which, when we try and want to discuss empty follicles, we have to keep one thing in mind, okay? That it is very easy to discuss theory of empty follicles. Okay, what is the actual challenge is how to face the patient with empty follicles. And no matter how much you read, no, all across the internet, all across all papers, you speak to anyone, currently people are no longer wanting to talk about management because current management is not so great. Okay, everybody wants to fight between, is it a true empty follicle or is it a false empty follicle? Okay, so that is a very good theory. What is true, what is false, we know the reasons for true are currently unknown, so no one knows it. Probably there is, early ovarian apoptosis is what people are saying. Many there is a beautiful community on that, on WhatsApp, where people are only discussing empty follicles across the world. I am a part of that. Okay, and what is false? So false is due to technical errors. Okay, so I am not here to justify what is right and what is wrong. I am going to tell you, one, what you should do to avoid it, and second, what you should do, okay, in order to improve it the next time, the first time when you have an empty follicle. Okay, so please try and understand this simple concept which I am now going to draw. When you have a dominant follicle, let's assume, Shilpa madam, everything is visible, right?
Yes, yes.
Okay, well,
You're not audible?
am I audible?
Yeah,
Yes.
now.
Okay, inside this cumulus cells is the presence of the oocyte. Okay, now for this oocyte to undergo rupture, okay, what is needed? Everybody knows this. We need a LH surge. Okay, what is important for us to understand is this LH surge has to be sustained and it has to be long. Okay, for a good LH surge, at the time of LH surge, what will happen is it will cause these gap junctions which are present here to break open. Okay, once these gap junctions which are present here will break open, inside this dominant follicle which we see, if I draw the dominant follicle which we see, what is going to happen is these granulosa cells are going to get thinned out. So let's say this one wall will get thinned out, and initially this cumulus oophorus complex will get released here inside. Okay, this gets released here, and then this oocyte gets thrown out from this window. Okay, it gets thrown out from this window, which we normally call as ovulation. But what are we trying to achieve in IVF? We are trying to achieve this LH surge. Okay, but we do not want ovulation to occur. So once you do this LH surge, this has to become loose, that is for sure. But we want to do a needle aspiration. So we put our oocyte aspiration needle and we want to aspirate this oocyte prior to that. Okay, now this leads us to empty follicle syndrome. Okay, now this is the basis of developing empty follicle syndrome. Okay, so first thing, just remember all the T's will come. Okay, so just you will be worried why, what T is he now talking about. Okay, so first is timing. Try to do your oocyte aspiration between 35 to 37 hours. Okay, if your oocyte aspiration occurs at less than 34 hours or more than 38 hours, okay, that is the situation where it is believed that this has not dissociated correctly. And even if you put your needle inside, okay, even if you put your needle inside, okay, it will not get released from there, due to which you will have a false empty follicle syndrome. That is the first thing which you have to understand. Okay, second, you have to understand that temperature is important. Now, what temperature am I talking about? If you ever read the packet of HCG 10,000 trigger, okay, it is said that you are supposed to store it in a dark place. Simultaneously, the temperature should be less than 25 degrees Celsius. Now, I know we all want to achieve this and we all want to achieve this, but many a times when we give patients the trigger to be taken at home, they may not follow this particular instruction very nicely, which causes the HCG 10,000 to get slightly denatured. So now you will say, Arey, how can it get denatured? It is available as a powder and solvent form. Many of places it is powder and solvent, many of places it is PFS. So what to do in that situation? Remember, this solvent, no, it has preservatives. So these preservatives get denatured, which causes loss of proper action of this HCG 10,000. So if the temperature or the cold chain, if I'll just get it down to that, if the cold chain of HCG is not maintained, then also you can have a false empty follicle syndrome because the LH surge will not occur very properly. That is the second thing which you have to keep in mind. The third you have to keep in mind is obviously the trigger. Now, please remember, we have discussed trigger. It has become a smash hit session. We have always recommended that when you are talking of normoresponder, the best trigger to try and give is your dual trigger. Okay, why are we talking of this dual trigger? Because when you give this GnRH agonist as a trigger, okay, it mimics the LH surge very similar to what occurs in nature. Okay. And because it mimics it very similar to what occurs in nature, you are allowing this particular mechanism of the grab junctions breaking very effectively. As a result of which, when you are previously experienced a patient who has had just HCG 10,000 trigger, your next trigger should almost always be a dual trigger in a previous empty follicle syndrome. Okay. Just remember that it is a very, very simple thing. For people who want to understand more about triggers, go through our masterclass on trigger and you will understand why I'm saying this. Okay. Is there any role of stimulation? Now remember, the standard across the world is to use a GnRH antag cycle. Okay. In a GnRH antagonist cycle only, you will be able to give a dual trigger properly, as a result of which you should understand that in any other case of previous empty follicle syndrome, your cycle of choice should be a GnRH antagonist cycle. Okay. Lot of times people will mention this, that okay, this is okay, I understand all these things, tell me something which I don't really know about this entire exercise. So yes, the answers to that are really very simple. What defines your empty follicle syndrome actually is one very important thing. Okay, remember, your empty follicle syndrome, true or false, but at this point we will talk of true empty follicle syndrome, is defined when you have normal stimulation which is given to the patient, where normal E2 values are achieved, because you need normal E2 values to achieve your LH surge. Okay. After that, a trigger has functioned properly is what we think. Okay. The trigger has functioned properly. But despite that, there is no COCs. Okay. Or if you have COCs, these COCs are empty. That is called as empty follicle syndrome. Okay. So people will say, okay, but then, we have heard that how do we understand if the trigger is given correctly? You are saying trigger. How do we know if the trigger is given correctly? Is there any criteria to mark on the paper that the trigger is given correctly? And do I have to assess my trigger is correct or not? So very simple. If you are in doubt, okay, at the time of OPU, you can do an HCG, UPT. Okay, if the UPT is strong positive, okay, if it is strong positive, that means your HCG trigger has acted. If in case you do quantitative estimation, your value will be anywhere between 20 to 200. Okay, it has got no predictive value in my humble opinion. If you have given GnRH agonist trigger alone, then people will say, why don't we measure FSH and LH to ensure if the LH surge is correct? And just like anything else, if the value of LH is more than 15 international units per ml, then we should consider it as acted. I don't believe in this. I will take a lecture on how LH kits measure the LH, and you will understand why I don't believe in it. So I personally don't recommend any form of testing if your trigger has worked. Okay. So now we've understood some theories. Now what do we do? Okay. So let's assume today morning, as I told, I have 12 pickups and I started aspirating the follicles. And our typical the thing on which everybody has really laughed across the nation, coming, drop. So first needle went inside. Okay. And my nurse started yelling. My nurse would never do that because that will be her last day at work. But let's assume the first aspiration has occurred, and first two follicles, because we don't aspirate follicle by follicle and send it for testing. So first two follicles have gone inside the IVF laboratory, and your embryologist or your biologist tells you no follicles. Okay. Now this is where you can take some action. When there is no follicles which is told by you, you can't really aspirate everything, finish it off, and then say कि अब मैं क्या करूं. This is your first prediction that okay, there is something wrong. Okay, this is your first prediction of an empty follicle syndrome. Something is wrong. Two follicles are already finished. Now what do we do? Okay, the best thing which you can do in a situation like this, see, by the time you do all this testing and all for OPU, even if you are wanting to do it, the minimum time window is 1 hour. And in that 1 hour, your, let's say, 36 hours would have become 38 hours. So all these guys are going to get ruptured any which ways. So you have to act on the table. So one of the things which we have realized is the most practical thing to do in a situation like this is to do something called as double aspiration. Okay, I will just show you how the double aspiration is done. You don't really have to use a double aspirating, pump. You don't have to push the media again inside and take the media outside through a double needle. We just use a single lumen needle. So we just have to prick those follicles again and aspirate them. That is the one thing you can do, double aspiration. The second thing which you can try, and it really works practically in my opinion, okay, is you should increase your aspiration pressure. Okay, your normal aspiration pressure is going to be between 120 to 150 or whatever you have kept it. You just make it more than 200. Just keep it 220, 230. I do understand some real die-hard embryologists are going to tell you, if you do that, there will be some problem to the COC. Yes, there will be, but the problem to the COC will come if you get the COC. Otherwise, there will be no problem to the cumulus ovorus complex. So this is one thing which you can try. But let's assume you have tried this also and you have tried this also, and your nurse still comes out and your biologist tells you, we checked everything, yaar. Nothing is there inside. Okay, andar kuch bhi nahi hai. It is empty. Now it is a proper empty follicle syndrome. Okay, so your nurse has told you no follicles. Okay, now in this situation, obviously the first thing is you have to tell your patient. Tell your patient honestly that, look, I tried everything under the sun and you have not got any follicles. So the patient will ask you, what next? What next? You, in this situation, you are supposed to critically evaluate your cycle and just remember these 4 things. Change your trigger. Okay. Now this is important. Okay. Change your trigger. Second, after your OPU, perform second stimulation after 3 to 4 days. Do not wait for the next cycle to come. This is like a double stim, because any which ways the follicles are growing inside. Okay. No pre-treatments. No form of pre-treatments, no pre-treatment, no antagonist, nothing. When I say change your trigger, my answer almost always is going to be to give a dual trigger. Okay. And very, very important, ensure everything is correct of cold chain. So I will give you what we do in order to do that. All our injections are given to the patients. Apart from the trigger injection, in our hospital, if anybody of you has visited, you are aware that trigger is given in the hospital. Okay, for Bombay patients. Okay, for Bombay patients. For patients in Pune, we give it at Kiran Kurkoti sir's place. For patients in other cities, we ask them to go to a doctor and take that injection. And that injection has to be taken very, very correctly, because this trigger injection is going to be the person who is going to determine the outcome of this next particular cycle. So please keep that in mind. Okay, please keep this point in mind. Okay, obviously we don't want to give any pre-treatments. We don't want to give any pre-treatment estradiol. We don't want to give any pre-treatment progesterone. We don't want to give any antioxidants. We don't want to do all this. Let's assume after you have changed point number 1, point number 2, point number 3, and point number 4, you repeated your oocyte aspiration and still your nurse has told her it is empty follicle only again. Okay, in this situation, I am going to comment of something small, which is an off-label indication. There is no such procedure only, but we have been started to doing it because we are a referral unit for empty follicle syndrome, and that is transvaginal needling. Okay, it's like transvaginal ovarian drilling. Very, very simple thing. What you are supposed to do is, after your oocyte aspiration is finished, okay, this ovary, just drill it with the needle through the same puncture, just past 25 punctures, at your places, 25 punctures at the place value. I don't know how it works. I don't know. Kindly don't ask me. I myself don't know how it works. But we have seen that transvaginal ovarian drilling works the best when you have normoresponder patients. Okay. And in the subsequent cycles, when you do your oocyte aspiration and you do your stimulation, usually in approximately 30% of the cases, you are able to retrieve cumulus oophorus complexes in patients who have empty follicles. Okay. The reason why we started doing this procedure is because the basic things which I spoke of are already finished. It is only then that these patients are sent to us for further management of empty follicle syndrome. And when these patients are then sent to us for further management of empty follicle syndrome, we have realized that this is one procedure, even if it is unindicated, even if it is off label, it is something which may work, and somebody who wishes to try can probably try implementing this in their practice. Okay. I also want to tell you that empty follicle, otherwise, if people want to run a thorough literature search, you can really try doing that. But empty follicle syndrome otherwise has no documented treatment which is considered to be the best possible treatment. Okay. As a result of which, you have to do this trial and error. And in out of 100, in 25% of the situations, with your trial and error methods, after you solve all the points which I have written down, in your next aspiration, you will be able to get oocytes. Okay. And I think that is something which you have to keep in mind. And I think that is something which is important. So with this, I finish 20 minutes of the session, and I will answer 4 to 5 questions from Shilpa madam, and rest of the questions we'll answer on WhatsApp. Yes, Shilpa madam.
Yeah. So have you noticed this empty follicles with usage more with such, or it doesn't matter? The stimulation.
I could not hear you. I could not hear you, madam.
Oh, sorry. So, does HMG or REC-FSH has any role in the incidence of empty follicles?
No,
or
absolutely not. Those are empty follicles will predominantly occur because there is some problem in the final LH search and not in the recruitment.
So does it mean that the ovarian response is poor? Do you correlate it with the ovarian aging or
honestly,
the age of the patient?
Honestly, very difficult to predict it, madam. Very, very difficult to try and predict it, to be very honest with you. But there are some people who will say that yes, empty follicle syndrome is mostly due to a underlying ovarian aging. But then we don't really know. I at the moment I don't support that theory.
Okay, and like how we notice batch-to-batch variation in HMG injections, do you believe that there will be batch-to-batch variation in HCG injections also?
Definitely, HCG is something which is commercially manufactured. So batch to batch, there will be some changes. But fortunately, HCG, the dose which is given is very huge, 10,000 units. So even if the efficacy is less by 10%, it should not ideally matter. And as a result of which I stated that next cycle, you should always give dual trigger.
Okay. So recurrent empty follicle syndrome. So for them, what do you advise? You said after trying all this 30%, you will be able to retrieve oocytes. But what about in the other 70%?
See, madam, most of these people, after doing 1 or 2 cycles and when they get empty follicles, what typically happens in today's time and age is in the first cycle itself, they will be counseled for donor oocytes. Okay, by the consultant. So by the time they finish their third cycle, even when we done transvaginal ovarian needling and still there is no follicle, patient is virtually ready to go ahead with donor oocytes in that situation in more than 90% of the times.
Okay, so you see about say 10 follicles, but the E2 is only about 400, 500. So
no, that should not be
on the day of the trigger. So in such situation,
if you have given letrozole along with it, then all that should not really matter. Okay, if you have not given letrozole, then it depends on how much is the time between the collection of E2 and the processing of E2. And if the time between collection of E2 and processing of E2 is less than 2 hours, only then your estradiol values will hold any significance.
So do you re-administer the HCG if after 1 or 2 oocytes have been?
No.
You don't.
No, I don't do that. I strongly recommend people who are trying to do that. See, that is a proposed treatment. It is not something which is invented by somebody. That is enough literature is available that you can give a booster dose of HCG and all these things. Okay. I don't think all that is really important. It will ultimately not give you follicles. The follicles which will come out of it are going to be out of a fluke, and most of it is due to the previous incorrect trigger, temperature of that previous trigger. It has got nothing to do with empty follicles, that particular thing.
Okay. Has any role or any increased incidence in empty follicles? Doing coasting for more than say 24 hours or even 48 hours?
I never do coasting, madam. No, I never do coasting, so I don't know.
Okay. So the needling that you mentioned, so that is without any energy source, right? I mean, just using the needle to
No,
it
it is
out.
without energy source.
As in like to puncture.
Just puncture it. It has got no energy source inside, madam.
Okay. So have you seen more association of these empty follicles with PCOS?
Difficult to predict. There is no such thing, madam. You can't really say that, but you can have a very high AMH, let's say AMH of, let's say 12, just to give you an example. And let's say you have 20 follicles, out of which you will get only 12 oocytes. You know, something like that can happen, but that is more to do with the mechanism of PCOS and less with empty follicles.
Okay. And what about the dosage of the gonadotrophins in the subsequent cycle? Do you advise them to increase the dose?
Standard
dosages. Follicles?
No need to increase. No need to increase the dosage. It has to be the standard dosages.
Yeah, I think I'm done with the questions.
Okay, so rest of the questions we'll answer on WhatsApp. For people who are having questions on how to give double trigger and what is it, we have taken master classes. Kindly spend some